Welcome to this deep dive. I am so thrilled you're joining us today because
Yeah, it really is a breath of fresh air.
exactly, a rare breath of fresh air. I mean, if you look at the news lately, it's incredibly easy to feel overwhelmed by just everything that seems to be going wrong across the globe.
Oh, absolutely. It's heavy.
It is. But today we are focusing on a major under-the-radar victory in global health. We're talking about a story that brings together cutting-edge genetic science, global logistics, and that absolute final grinding push to completely eradicate one of history's most notorious diseases, which is polio.
It really is a profound moment in medical history.
Ah.
I mean, eradicating a human disease is something we have only ever successfully accomplished once before.
Right, with smallpox.
Exactly with smallpox.
Yeah.
Getting to the absolute finish line with polio requires this incredible alignment of technology funding and sheer human willpower. And the source we're examining today gives us a very clear window into exactly how that complex machinery is operating right now.
Yeah, our sole source for this deep dive is a departmental update that came straight from the World Health Organization. It's dated very recently, February 13, 2026. And the title is WHO Prequalifies an Additional Novel Oral Polio Vaccine Strengthening Global Outbreak Response.
That's a bit of a mouthful.
It is a mouthful, but our mission today for you listening is to figure out why the WHO is going out of its way to pre-qualify a brand new polio vaccine when we've had effective vaccines for decades. I mean, what does this specific announcement actually mean for the global effort to finally wipe this disease off the map?
Okay, let's unpack this. To start us off, I want to loot that term right in the title. What does pre-qualification actually entail when the WHO uses it?
Right, so pre-qualification might sound like standard bureaucratic paperwork, but it is actually one of the most vital mechanisms in global public health. When the WHO pre-qualifies a vaccine, they are conducting a rigorous, intensive evaluation process.
So it's not just a rubber stamp. No, not at all. The designation officially indicates that the vaccine meets very strict, universally recognized international standards for quality, safety, and efficacy. It basically proves that a specific manufacturing facility is producing a product that's ready for global immunization programs.
Yeah, so it's the ultimate gold standard seal of approval. It tells any nation that this specific product from this particular factory is safe and effective. But beyond the safety aspect, what is the practical purpose of this designation?
The real operational value is that pre-qualification serves as the official green light for massive United Nations procurement agencies.
Like UNICEF.
Exactly like UNICEF. Once a vaccine hits that pre-qualified status, UNICEF and other global entities are authorized to purchase it in massive bulk quantities. They can then supply it to multiple countries across the world to control virus transmission. Without that specific WHO designation, those massive global supply chains simply cannot purchase or distribute the vaccine.
That sets the stage perfectly for the new player mentioned in this WHO update. The newly pre-qualified product we're talking about today is manufactured by a company called Biological E Limited, or BioE, which is based in India. And what stood out to me in the source is the collaborative nature of this milestone.
It's a great example of international cooperation.
Yeah, because BioE is manufacturing this using their own in-house bulk vaccine, but they are doing it following what the WHO calls a technology transfer from another manufacturer, PT Biopharma, over in Indonesia.
That technology transfer is a highly significant detail. PT Biopharma in Indonesia had already been manufacturing this novel vaccine, and they had earlier WHO listings for it. They even supplied the bulk material for BioE to formulate and fill previously.
Okay, so they were already working together.
Yes, but now BioE in India is producing their own in-house bulk vaccine entirely from scratch and has achieved their own pre-qualification. If we connect this to the bigger picture, you can see the strategic maneuvering of the global health community. They are actively diversifying the manufacturing base.
But if Indonesia is already successfully making this vaccine and has the WHO listing, why is the global health community spending time and resources to get a second facility in India up to speed?
It comes down to supply chain resilience. Relying on a single factory in one country leaves the entire global eradication effort vulnerable to a single point of failure.
Oh, like if something goes wrong at that one plant.
Precisely. Consider what happens if there's a severe supply chain disruption, a natural disaster, or even just a sudden massive spike in global demand. By bringing BioE fully online with her own independent pre-qualification, the WHO creates a much more robust, sustainable supply of this quality-assured vaccine.
So it's about having a backup plan.
A very active backup plan, yes. It guarantees that when a country experiences a sudden outbreak, the international community has the physical inventory ready to ship immediately.
That brings us to a really fundamental question. I'm sure if you're listening to this, you might be wondering, why do we even need a novel oral polio vaccine in the first place? We have been vaccinating against polio since the 1950s. Most people have heard the names Jonas Salk and Albert Sabin. Why innovate on something that has already brought global case numbers down so dramatically?
To understand the need for a novel vaccine, we have to look at the tools those two scientists created. Jonas Salk developed the first successful polio vaccine, which was an injection. It used an inactivated or dead virus.
Right, the shot.
Yes, and the Salk vaccine is fantastic at protecting the individual who receives it from paralysis, but it doesn't build strong immunity in the gut. So if that person is exposed to polio, the virus can still multiply in their intestines and be passed on to others.
So it protects the person, but it doesn't necessarily stop the virus from circulating in the community. And that is where Albert Sabin's vaccine comes in, right?
Correct. Sabin developed the oral polio vaccine, which is given as drops in the mouth. This vaccine uses a live but severely weakened form of the poliovirus. Because it goes directly into the digestive tract, it builds intense mucosal immunity in the gut.
Meaning it stops it where it enters?
It stops the virus dead in its tracks, preventing the person from shedding it and passing it on. That is why the oral vaccine has been the primary tool for eradication. It actually stops transmission. But it comes with a defining paradox.
The source refers to this paradox as a circulating vaccine-derived poliovirus type 2, or CVD-PV2. You mentioned the virus is excreted into the environment after someone gets the oral drops. Doesn't that put the rest of the community at risk?
That is the core of the issue. When a child receives the oral drops, the weakened virus replicates in their gut, building their immunity, and then it is excreted. In a highly immunized population, this is actually beneficial because it provides passive secondary immunity to others who come into contact with it.
A sort of bonus immunity for the neighborhood.
Exactly. The crisis occurs in under-immunized populations. If the overall vaccination rate in a community is low, that weakened excreted virus can circulate locally from person to person for a very long time.
And as it circulates, it changes.
It mutates. Over months or years of uninterrupted circulation, the weakened virus can genetically revert to a form that behaves just like the wild poliovirus. It regains the ability to paralyze people.
Wow.
This mutated virus is the circulating vaccine-derived poliovirus. We end up in a tragic situation where the very tool used to fight the disease is occasionally under specific conditions of low community immunity seeding new outbreaks.
That is a staggering scientific reality. We were using a fire extinguisher that, under the wrong conditions, could spark a new fire.
That's a perfect analogy.
And the source explicitly points out how the NOPV2, this novel oral polio vaccine type 2, solves this exact problem. Before we get into how it solves it, just so we are all on the same page, the report calls it a monovalent vaccine. What does that mean in this context?
Monovalent simply means the vaccine is designed to target only one specific strain of the virus. There are 3 types of wild poliovirus, type 1, type 2, and type 3, while type 2 was officially eradicated years ago.
Okay.
So this monovalent vaccine is specifically formulated to only contain the weakened type 2 strain, allowing health workers to target these specific vaccine-derived type 2 outbreaks without introducing the other strains into the environment unnecessarily.
Got it. Now, looking at how they fixed the mutation issue, the NOPV2 seems like a marvel of modern genetic engineering. Compared to the traditional monovalent oral polio vaccine, this novel version has been designed to be highly genetically stable. It's almost like they locked the virus's DNA into a safe so it cannot change its combination.
That is an excellent way to visualize the science. The researchers went into the RNA of the weakened Sabin virus and secured the specific genetic sequences that were prone to mutating back to a dangerous, paralyzing state.
They literally engineered locks into it.
They engineered locks into the genome. What makes this such a monumental achievement for epidemiologists is that they secured this genetic stability without sacrificing the vaccine's potency. It significantly reduces the risk of seeding those new vaccine-derived outbreaks, but it retains its incredible effectiveness at rapidly building gut immunity and interrupting virus transmission.
It's a much sharper, safer tool for these final stages of eradication. And what makes this deep dive so encouraging is that this isn't just theoretical science happening in a lab somewhere. This progress is translating into real, tangible gains on the ground.
Definitely.
The WHO update included a powerful quote from the WHO Director General, Dr. Tedros Adhanom Ghebreyesus, from the 158th session of the WHO Executive Board. Looking at the case numbers he cited from last year, it is a staggering drop. Can you walk through what those figures actually look like geographically?
The data is highly encouraging. Last year, there were only 41 cases of wild polio reported globally. And those 41 cases were confined entirely to just 24 districts across Pakistan and Afghanistan.
Just 41 cases.
Yes. To understand the momentum here, we have to look at the previous year, 2024, where there were 99 cases spread across 49 districts.
Cutting the number of wild cases by more than half and having the geographic footprint of the virus in a single year. And that is happening in Pakistan and Afghanistan, which are some of the most complex, difficult operating environments in the world. How does this novel vaccine fit into that specific strategy?
The NOPV2 is indicated for active immunization across all age groups, and it's currently authorized for emergency use, specifically in response to outbreaks caused by poliovirus type 2.
So they have it ready to go.
Right. Whenever the Global Polio Eradication Initiative, or the WHO, identifies an outbreak, this is the tool they deploy. It has already been used in numerous outbreak responses reaching hundreds of millions of children. The surveillance data shows it is actively shrinking those tricky CVDP2 transmissions in several affected countries.
So what does this all mean? If you're listening and trying to connect these dots, it means that the dramatic drop in case numbers isn't an accident. It is the direct result of vaccine innovation, designing a genetically stable virus working hand-in-hand with aggressive global deployment.
Yes.
Expanding the pool of pre-qualified manufacturers, like bringing BioE online in India, guarantees that these countries can continue to respond rapidly and effectively.
It ensures the supply can match the strategy. We have the right tool, and now we are ensuring we have enough of it to finish the job.
I want to shift gears here because while the genetic engineering is incredible, there is an unsung hero in all of this. It's a topic that rarely makes the front page, but without it, none of the science we just discussed actually matters.
Let me guess, logistics.
I am talking about logistics. The WHO source provides some highly specific details about how this BioE vaccine is packaged and stored. Looking at the specs, the temperature tolerances really jumped out at me. From a logistical standpoint, why are these specific storage details so vital?
Logistics is the arena where global health strategies either succeed or fail. You can engineer the most advanced vaccine in human history, but if you cannot keep it viable until it reaches the mouth of a child in a remote village, it is completely useless.
It's just expensive liquid at that point.
Exactly. The cold chain, the uninterrupted series of storage and distribution activities maintaining a given temperature range, is the backbone of any immunization campaign.
Let's look at the exact specs for this BioE vaccine. It comes in 20-dose and 50-dose vials. According to the update, it has a shelf life of 24 months when stored at or below -20 degrees Celsius. But the source notes it can also be safely stored for up to 6 months at standard refrigeration temperatures, which is +2 degrees to +8 degrees Celsius. Why is that 6-month window at normal fridge temperatures such a big deal?
What's fascinating here is the physical journey of that vial. It starts in a state-of-the-art facility in India, moves onto a cargo plane, and lands at a national depot in a capital city where -20 degrees is easy to maintain.
Right, they have massive freezers there.
But the final frontiers of polio eradication are not in cities with perfect power grids. They are in remote mountainous regions, active conflict zones, and rural villages with highly unstable electricity.
Places where finding a deep freezer is practically impossible, but running a regular medical refrigerator on a portable generator or solar panel is realistic.
Precisely that. Being able to move a vaccine from a deep freeze into a standard cold chain, like a regular medical fridge, or a portable cooler packed with ice, and knowing it will remain potent and safe for a full 6 months, is an operational game changer. Health workers can strap coolers to motorcycles or carry them on foot over rough terrain, taking days or weeks to reach isolated populations without the constant anxiety that the vaccine is spoiling.
The operational flexibility goes even further. The source mentions something called the WHO Multi-Dose Vial Policy, or MDVP. Under this policy, once a health worker actually opens a vial of this NOPV2 vaccine, they can keep it and safely use it for up to 28 days. That seems like an unusually long time for an open vial of medicine.
That 28-day rule is a masterstroke for campaign efficiency. Imagine a health worker opens a 50-dose vial in a small settlement, but they only find 30 children to vaccinate that afternoon. With older or less stable vaccines, those remaining 20 doses would likely have to be discarded at the end of the day.
Because they would go bad.
Yes, and when you are fighting a global disease and relying on finite funding, wasting 40% of a vial is devastating to the campaign.
It is literally throwing life-saving resources away because the sun went down.
But with the genetic stability of the NOPV2 and the MDVP guidelines, that health worker can safely cap the vial, keep it in their cooler travel to the next settlement the following morning, and use every single drop. It eliminates massive amounts of waste and maximizes the impact of every single dollar spent on these outbreak response campaigns.
It really highlights how you need the brilliant lab scientists to design the RNA, but you equally need the field operatives and policymakers to design the vials and the temperature rules. It takes both sides to make this work.
The global health community is deeply aware of this multifaceted challenge. The WHO update touches on this directly when summarizing the recent executive board discussions on poliomyelitis, which took place between February 2nd and 7th, 2026.
Right, the 158th session we mentioned earlier. The delegates there were intensely focused on what is required for this absolute final push. The source outlines a three-pillared strategy for the remaining endemic areas, almost like a battle plan. The first pillar they emphasize is maintaining high-quality surveillance. But what does surveillance actually look like on the ground? We aren't just waiting for doctors to report a paralyzed patient, are we?
No, definitely not. If you're waiting for a child to show up paralyzed, the virus has already been circulating silently in that community for months. High-quality surveillance means actively hunting for the virus's footprint.
How do they hunt for it?
Health workers are conducting environmental sampling, meaning they are physically going out and dipping collection bottles into open sewers, wastewater treatment plants, and rivers. They test those water samples for the genetic signature of the poliovirus. It allows them to detect an outbreak before a single person ever shows physical symptoms.
That makes the second pillar make much more sense, continuing vaccination and rapid outbreak response. If you catch the virus in the sewage on a Tuesday, you need the supply ready to deploy a mass vaccination campaign by Friday, which is exactly where this new BioE prequalification comes into play.
The faster you respond, the smaller the fire you have to put out. And the third pillar is simultaneously addressing the circulating variant poliovirus outbreaks elsewhere.
So hitting it from all sides.
Yes. So the strategy is fighting the wild virus in the remaining districts of Pakistan and Afghanistan, while aggressively using the NOPV2 to stamp out the vaccine-derived outbreaks in other under-immunized regions around the world.
But reading through the source, it is clear the delegates didn't just stop at the medical and tactical necessities. They placed a massive emphasis on the human element, the non-medical geopolitical realities of eradication. They underscored that getting to zero cases requires sustaining high-level political commitment and ensuring access for health workers. In conflict zones, ensuring a health worker can safely enter a village without being targeted is a massive hurdle.
It is arguably the most difficult hurdle remaining. The delegates also highlighted the absolute necessity of predictable financing. You cannot plan a complex multinational logistics operation, coordinating factories in India, air freight, and local health workers, if you do not know if your funding will exist next quarter.
Right, the money has to be there.
And finally, they stressed the need for close cross-border coordination.
Because a virus doesn't care about a line drawn on a map.
Polioviruses do not respect national borders or political disputes. If one country is executing perfect surveillance and vaccination campaigns, but their neighboring nation is faltering due to political instability, the virus will simply cross the border. The political leaders of neighboring nations, even those with historically strained relations, have to share surveillance data and coordinate their campaign seamlessly.
That's a huge ask.
It is. These non-medical political factors are going to be the deciding variables in translating the recent drop in cases into a permanent, irreversible eradication.
It is a monumental undertaking. So as we wrap up this deep dive, I want to quickly summarize the journey we have taken you on today. We started with a single, highly bureaucratic announcement, the WHO pre-qualifying a new polio vaccine from a manufacturing company in India. But as we unpack the layers, it reveals itself as a masterclass in human ingenuity and global cooperation.
It really does.
You have complex technology transfers moving from Indonesia to India to secure the global supply chain. You have cutting-edge genetic engineering that literally locks the RNA of a live virus so it cannot mutate and harm the people it is meant to protect. And you have an astoundingly precise global logistics network that allows United Nations agencies to pump these stable vaccines out across the most remote corners of the globe.
As you reflect on this information, I hope you consider that while wiping out a disease sounds like a triumph belonging solely to high-level laboratory science, it actually relies just as heavily on rugged operational flexibility on the ground.
Yeah.
The fact that a vial of this genetically advanced vaccine can survive in a standard everyday refrigerator for 6 months and stay open for 28 days without spoiling is just as crucial to stopping polio as the genetic locks engineered into the virus itself. It is the perfect marriage of high science and practical, real-world logistics.
I want to leave you with a final thought to mull over as you go about your day. When we look at global eradication efforts like this, the journey from millions of cases a year down to 99 cases, that is a triumph of mass mobilization and basic vaccination. Incredible progress. But that final journey, the grueling push from 41 cases down to absolute zero, requires an entirely different level of precision, genetic innovation, and unwavering global political willpower. It makes you wonder what other global challenges are currently stuck in that difficult final 1%, just waiting for their own radically novel solution to finally push them over the finish
Yeah,
lines.
a profound question, and one that applies to so many critical challenges we face today, far beyond the realm of medicine.
Well, thank you so much for joining us on this deep dive. We love taking these complex sources and breaking them down with you. Keep questioning, keep learning, and we will catch you next time.